And I'll share my screen, sir.
Yes.
I think we should start, Deepika.
I'll start, ma'am.
Yeah.
Okay. A very good evening to one and all. We welcome you to the online teaching program for postgraduates in pathology. The title of today's talk is Value of Clinical Notes in Autopsy. This is our presenter for the day is Dr. Anita Burgess. She's the lab director and consultant oncopathologist. And our chairperson for today is Dr. Purva Patil, Professor of Pathology, JJ Hospitals, Mumbai. Moderators today are Dr. Ramaswamy and me. And our webinar hosts are Dr. Sumit Gujral and Dr. Anita Burgess, ma'am. Few reminders. If you have any connection interruption or if the WebEx session is loading slowly, please log off and log in back again. Kindly close all the applications except WebEx meetings. Clear the web browser cache and delete all the temporary files and cookies. If you have any queries, please type in the chat box only. There are a few disclaimers. I now request Dr. Anita Burgess, madam, to kindly deliver her talk.
Thanks, Deepika. Let me share my screen, if I can manage it. There's somebody else's screen. Have you stopped sharing, Deepika?
I stopped.
All right, now you can share my, you can see my screen, I think. Yes?
Yes, ma'am.
All right. So good evening, everybody. And today, in this continuing three-part lectures on autopsy pathology, I'm going to talk not so much about the autopsy and how to do it and its importance and everything else, but the importance of reading the clinical notes. Clinical notes accompany, the requisition for an autopsy every time. Actually, in the clinical notes, you have the requisition and the sign-off by whoever is authorizing that autopsy. If it is the patient's relatives, then the relatives sign, somebody signs off from the relatives. If it is an autopsy that has, forensic reasons, then of course it's signed off by a hospital administrator or, the police or whoever it is who has authorized that autopsy. But whatever it is, I think it's important to have the clinical notes and to read it. In fact, nobody should start an autopsy unless you have the clinical notes and actually check the authorization. Now, you've had this done before, but I thought it was worthwhile just reiterating again why we need to have a clinical autopsy. And you've heard all the pros and the cons and the discussion on why autopsy rates are going down, and some people bemoan the fact that the rates are going down. Other people feel that they're going down because there is so much investigation that happens during life that the autopsy produces very few surprises. Whatever it is, the autopsy still plays a very important role, I think, in teaching, also in clinical medicine. And of course, if you ask for the reasons why autopsies have been traditionally done and why they should be done today, the first one, of course, is the cause of death. When a cause of death is not known and it cannot be signed off, or in other words, you cannot assign a cause of death, or you don't know the final or terminal event for death, then, an autopsy can be quite illuminating, because you may find something that obviously has missed clinical attention. But I think a very important part of why an autopsy needs to be done is to look at the evolution of the disease, whatever the disease is, in the patient during life. And this was brought home to me very, I would say, forcefully by a professor of mine who was a professor of neurosurgery. And he was a very acerbic gentleman who's he was eccentric, to say the least. And he never failed to attend an autopsy when one of his patients had not made it. And in those days, neurosurgery isn't what neurosurgery is today. Today, both anesthesia and clinical care and neurosurgery are so much, advanced. In those days, we had very primitive neurosurgery. Also, the number of antibiotics and so many other facilities that are available today, supportive care in general was very poor. And there were many adventures, may I say, in neurosurgery, and the patients would end up on the autopsy table. And Dr. Daftari was his name, and I remember him, despite the fact that he was very acerbic, very eccentric, and he was a misogynist to boot. And a misogynist is someone who doesn't like women very much. So, when you were an autopsy prosector, and that too one of the lowly ones who was a resident in pathology, and you had to face Dr. Daftari, who came with his whole phalanx. He had about, in those days, 5 or 6 residents, and they would all march behind him. It was a really scary thing. So there I was doing an autopsy on one of his patients who had died post-operatively. And I can't remember now what the case was, that, but I knew it was neurosurgery. And I arrived in the autopsy room, and our PM, as we call them, PM attendant, was getting the body ready. And I said, hurry up, please, because I'd like to finish before Dr. Daftari comes, and then I'm not there and you can show him the organs. And he, sort of hurried up. And obviously we had to look at the brain first, because this was a neurosurgical problem. And he took out the brain, and the brain was kept over there, and it was so obviously a pyogenic meningitis. So, this was post-operative sepsis, and there was pyogenic meningitis, and I was very glad that I found the cause of death. And even if he turned up there to see it, I could, sort of just hand him the forceps and say, this patient died of pyogenic meningitis. And I had finished doing that, and also dissecting the other organs, when Dr. Daftari walked into the room. And of course, I picked up the forceps, and he rapidly said, this is a male patient, so-and-so, 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 who was, died post-operatively, and the cause of death is pyogenic meningitis. Now, Dr. Daftari had a very peculiar way of shaking his head. It's called titubation. And I'm sure those of you who have been through clinical medicine will know. It's a kind of a shaking of the head that way. And he started to do this whenever he spoke. And he shook his head, closed his eyes, and said, no, doctor. I don't want to know why this patient died. I want you to explain to me why he lived so long. And that was his way of putting down a female resident pathologist. And frankly, that was one time in my life that I was entirely flummoxed. I had no idea how to answer him. I was furious as well, because I thought, here I had done everything that I was supposed to do, And this man walks in and in his usual cavalier, attitude, just put me down. Anyway, there was nothing you could say, to a big boss like Dr. Daftari. I could see the smirks and the grins of all his entourage at the back of him, standing behind him. And he desultorily picked up the forceps and, sort of touched the brain, looked at the incision in which he had made, and so on and so forth. And in 5 minutes, he turned his back and walked out. Now, I was really, really furious. I was upset. And I went up to have my shower. And while, the thing was going round and round and round in my head, I said, I should have been able to say something to him. I should have been able to give him back in his own coin. And then, it suddenly dawned on me that what Vijay Daftari had asked me was one of the most profound questions that you can ask any pathologist. Because when we see tissues, whether it is after surgery or after, at autopsy, or for that matter, even a blood sample, what are we actually looking at? We are looking at one particular moment in time in a patient's existence. But there is a lot that has gone before, and a lot, if the patient is alive, that will happen afterwards. The autopsy, of course, is a final event in a patient's existence. And there are so many things that have happened, and we are looking really in an autopsy at the end of a dynamic process. And my fury and my, my feeling of frustration just settled down. And I said, I think what he asked me was something that is not only profound, but well within my ability to answer. And honestly, that changed my life. It changed my life as a surgical pathologist. It changed my life as a, histopathologist or an anatomic pathologist. Because now I never look at something only at, in the context of where we are at a particular moment of time. And I remember this patient very, very vividly, because when I went back to the histopathology, after the histopathology was ready, I saw all kinds of changes, which I would have seen, but perhaps not integrated into this, the dynamic process that Dr. Daftari had managed to make me realize was at the back of all disease in patients. And I could see what happened when this patient had gone on the ventilator, what kind of issues were there in the lungs, what his original disease had done to the brain and to all the other organs. Of course, there was sepsis, so there was a lot of, sort of abscesses in many organs, the sort of thing that you don't really see much today. And the whole thing made a dynamic whole. So I'm very grateful to Dr. Daftari, and I'm giving you this, sort of little story, because those of you who do autopsies, or for that matter, even do surgical pathology, it's so important to understand what happens before you see that one, sort of organ or tissue or section in, at one moment of time. All right, having said that, this is one of the lessons that you can learn in clinical medicine. And I will tell you something, what the autopsy often teaches you, or for that matter, a careful examination of anything, it teaches you to be humble. Humility is one of the biggest lessons that you learn by doing an autopsy. It's a lesson that all clinical medicine should teach you, but the autopsy most of all. And I won't go into forensic medicine, because that teaches you a whole other, and sometimes you don't expect that the autopsy that you're doing, which for all practical purposes was a clinical autopsy, sometimes throws up lessons in forensic medicine. It's any number of times you have found that a patient who has died after a surgical operation and sepsis, you find a reason for where that sepsis came. It may be a swab, it could have been, you know, something that was not only necessarily left behind, but you know, an inadvertent misadventure during surgery, etc., etc. So I think that the autopsy teaches you many lessons, and that's the reason why we do autopsies. But now let's come to why should we read the clinical notes. Well, the first one, of course, is the most important. Check the identity of the individual and, of course, the authorization. That should have been in this slide. You should never ever start doing this without checking authorization and also the identity of the individual. It also, when you have read the clinical notes before you get to the autopsy, it kind of primes you as to what to expect in what you're going to find, what you should look for. So that if you do that, the notes often give you a pointer. Then you can do a more focused dissection. You can also, anticipate what kind of ancillary techniques you might need, whether it's microbiology or it may be molecular pathology. In other words, you may need to send something off for PCR. You may need something off for virology if there is a question of a viral illness over there. It may be that you suspect a poisoning or some other thing which allows you to prepare yourself to send off for these ancillary investigations. And if you've read the notes, then you come prepared to, with all the paraphernalia that you might require. Sometimes you might need electron microscopy in looking at whatever that particular case might be about, and then you should get your little bottle of glutaraldehyde or whatever else you require. Particularly, say, if a patient has died, of some kind of kidney disease which was not elucidated well during life, etc. And you may need these ancillary investigations. Sometimes you find things at autopsy and you do not find the explanation for those findings in the morphology that you see. And this is where the clinical notes would help you to explain why you are seeing what you are seeing at the, during the autopsy. And of course, the clinical notes will be very, very helpful when the cause of death is not very apparent in the autopsy room, and there are no morphological findings. Sometimes you don't find morphological findings even on histopathology. And then the clinical notes can be very helpful to try and tie up what it is that happened, not just at the end of life, but the clinical course of why this patient ended up on your autopsy table. Now, let's start with, and I'm going to do it through the cases that I myself have either done or supervised in the autopsy room. So we will go through, I think there are about 6 cases, and we'll try and elucidate how the clinical notes came to one's aid. Now here is the first case. Is a male who's 65, is a chronic smoker, and he had cancer of the anterior tongue and the floor of the mouth, for which this big operation, a commando operation with reconstruction. So he had half his face that was removed along with the tongue, etc. And it was beautifully reconstructed. Now, he died in the ward on post-operative day 4. And this being a post-operative death, and they didn't seem to have a reason as to why this man had died, they asked for an autopsy. And there was, in the autopsy findings, everything else seemed to be fine. The wound was fine, or all the other things, the heart and so on, were fine. But the lungs were very heavy and boggy. There was froth on squeezing. Now, you know that when you have that kind of thing, there is massive pulmonary. So that the immediate cause of death was very obvious. This patient had died of pulmonary edema. So we knew that. But the question was, what caused the pulmonary edema? Now, you know that there are several causes of pulmonary edema, and I've put them up over here. And if you would like to write in the chat box, what do you think could have been the cause of pulmonary edema in this patient? You can write 1 if you think it's 1, or 2A, or 2B, 2C, 2D, etc. And perhaps Deepika or Ram could tell me because I can't see what is being answered. If you could let me know what people are saying. Deepika, Ram?
Ma'am, most of them, they start feeling it is fluid overload, ma'am, 2E.
2E, okay. They're very good clinicians in those who are watching over there. I think it was unlikely to be sepsis. It could very well have been cardiogenic because the man's a smoker. It is obviously he is his heart may not have been very, very good, nor his lungs being very good. Viral infections, now that's a bit funny for somebody who's just had an operation. High altitude sickness. Well, he was on the 2nd floor. He certainly wasn't on the 12th or the 18th or the 25th floor now, as many patients, many hospitals have these very high. I'm just joking. And of course, it could have been a drug reaction. Yeah, why couldn't it have been a drug reaction? He was obviously on a number of medications, so it could have been a drug reaction, or of course, a fluid overload. Okay, so what did the clinical notes reveal? And this is something very simple. The patient was not on oral feeds. That was the first thing that I looked at. Okay, and I must say that when a resident was doing this autopsy, and he was having a merry time squeezing the lungs and saying, "See, pulmonary edema, pulmonary edema." Okay, and I said, "Yes, but can you tell me what is the cause of this pulmonary edema?" And he looked at me blankly and said, "I don't know." I said, "Did you find a morphological cause for pulmonary edema in this patient?" And since he looked blank, I said, "What are the causes of pulmonary edema?" And he had the gall, which very few residents, I must say, had the gall to answer, me in that way. He said, "But that's a third MBBS question. Why are you asking it to me now?" This resident is now a very grown up, very successful physician. I mean, he no longer practices pathology in that particular way, but I chased him out of the thing. I said, "I am going to finish this autopsy. You are going to find the causes of pulmonary edema and come back and then tell me why this patient has pulmonary edema." In the meantime, I read the notes, and the patient was not on oral feeds. The patient was a hypertensive on beta blockers, okay? And the input-output charts were not signed by a doctor at all. So I looked up the input-output charts and I found that this patient had a fluid overload due to overinfusion, okay, in a patient who was not on oral feeds and who had hypertensive heart disease. So it was a combination, I would say, of a heart that was pumping against tremendous pressure. Of course, he was on beta blockers and so on. And he was given, so much fluid that the heart just could not cope with, the kind of pressure it had to overcome. The left ventricle failed, and this was left ventricular failure in a patient who had fluid overload. And this was a very useful lesson which was discussed at the mortality meeting. And every time you do this sort of thing, there are lessons which can be given and lessons that can be learned for people who are caring for these patients. That, in a simple case like this, the doctor should have signed out on input and output charts, which meant that he would have noticed that there was a fluid overload. So good, a very good answer to all of those who said fluid overload. Okay. Now, let's take cases 2 and 3. Both of these were very similar and they happened within, say, 2 or 3 weeks of the deaths happened within 2 or 3 weeks of, one another. Yeah, these were males and they were not very elderly given our, present times, but in the 30 years ago or 40 years ago, 71 and 68 we considered old. Today, they're not considered old because our age has just been getting older and older, and the median age at which Indians also are dying has crept from 52 to now, if I remember right, is about 67 or something. So these were not really very elderly, but nonetheless, in those days they were considered old. Okay, both had a wide excision of cancer of the buccal mucosa, one with and the other without a marginal mandibulectomy. Okay, so they were both on oral feeds, so there was no question here of having input-output charts, etc., being looked at. They were due for discharge on post-operative day 7 and 8 respectively. So they were well. They were walking about in the ward. They were sitting up, eating, etc. And they died suddenly, both of them, on the night before they were due to be discharged. And again, on autopsy, except that this wasn't done by the same person who did the last autopsy that I told you about, the cause of death, immediate cause of death, was massive unexplained pulmonary edema in both cases. Okay, now all of you know this. Now you tell me, what do you think was the cause of death in these patients who 68, 71, they were obviously fit for surgery and they had gone through, the surgical procedure very well. They were up and about. They were walking about in the ward. They were on oral feeds. So just write what you think in the chat box. And I think viral infection and high altitude sickness is just there. It's one of the non-cardiogenic causes of death. It's very unlikely that it is fluid overload. So what do you guys think?
Majority think it is cardiogenic causes. What most
Cardiogenic causes. Okay. Yes, that seemed to be, that these were elderly patients, but they, to die suddenly, just before, and there were no symptoms or anything of that. They just died suddenly on the day. Actually, it was the night before they were due to be discharged. Discharge papers made out, everything. Next day, the relatives to come to take them home. Okay, so they didn't see, we had to do, of course, we looked for everything. There was no fresh thrombus in the coronaries. The left ventricles were not particularly, hypertrophied or flabby or any other such thing. It didn't look like the heart was the cause of this. So what did the clinical notes reveal? Both patients had complained of pain at night. That my wound is hurting or some sort of thing. And the nurse called the resident doctor, and the resident doctor advised intravenous pentazocine. We call, the trade name is Fortrin. I don't know how many of you know about this. Over the phone, and he used to jara IV Fortrin lagao. Okay. And both patients died suddenly after that, within 2 hours of the pentazocine being given. Okay. Now that was what was noted in the chart. When I went into the into the effects, because that seemed the only thing. When I did the first autopsy, obviously I had no idea that I would come across a next autopsy in a patient with this similar sort of phenomenon. I wasn't sure what the cause of death was. Sometimes, you can have a cardiogenic cause and not even be able to find it morphologically. But I went into this thing, 2 hours after complaining of pain and getting an intravenous injection. So I went into the cause, to look for what can pentazocine actually cause. And to my surprise, I discovered that pentazocine can cause an idiosyncratic adrenergic effect, which is a sudden release of adrenergic compounds from the adrenal glands. And in anybody, and this just shoots your blood pressure up very suddenly. Nobody would know that your blood pressure is shot up because nobody is monitoring your blood pressure at that moment of time. And this can cause acute left ventricular failure where the ventricle is not, the healthiest. But let me tell you that this is not just in elderly people. Okay, in elderly people, it can be more devastating. But I have actually seen a young woman under anesthesia who had this idiosyncratic adrenergic effect, and the anesthetist gave, like it's commonly given Fortrin Finargan is a very good sedative that they give, and suddenly this woman started frothing at the mouth. And of course, the patient was under anesthesia. You could, sort of revive her. And this happened in somebody whom I knew. And I had already done these 2 autopsies on these patients and had figured out that pentazocine can have this adrenergic effect. And when I said that to the anesthetist, she was extremely surprised. She said, "Oh, I use this so routinely, but thank you for telling me because I will be careful about it." And when she consulted other anesthetists, they told her that this is a well-known phenomenon. Okay, so this patient actually died of it was a drug-related cause. Now I'll tell you that in the hospital where I was working, when this came out, all intravenous pentazocine was banned unless it was in a supervised setting. It's an extremely good analgesic. There's no 2 ways about that. Pain relief is almost immediate and very good, but there are, and this is not a regular effect, it is an idiosyncratic effect. Okay, let's go now to, case number 4. And this was a 46-year-old male who was severely cachectic. It was very obvious that he had a malignancy, he had obstructive jaundice, there was a malignant tumor of the pancreas. His bilirubin was 16 milligrams per deciliter. And he, came into the hospital to have a CT scan for staging. And he died 20 minutes after this CT scan for staging, okay? And the autopsy confirmed that he had a pancreatic carcinoma with biliary obstruction. Now the question was, it's very easy to write the cause of death. Pancreatic carcinoma with biliary obstruction, so that's, taken as the man died of advanced carcinoma of the pancreas. But this thing was not the explanation that I could stomach, okay? What was the immediate cause of death? He came in there to have a CT scan for, staging his pancreatic carcinoma. And why did this patient, die when he arrived unaided to the radiology center? That means he came unaided to the hospital to have his CT scan. There had to be something else, okay? And certainly it was not the cause of this sudden, well, I wouldn't say it was sudden, but the cause of death was not available in the morphological findings, except for the fact, of course, that he had the carcinoma of the pancreas, he was cachectic. Okay. Well, What do you think? Acute cardiac death again? Do you think, this was now his pancreatic cancer was so advanced and his time had come, like people say. Now, the body has kind of just given up. Life has gone out of his body. I was curious. So I got into the clinical notes and I followed the last journey of this cancer patient from the time he came to the CT scan room until he, his autopsy was authorized. And it's very interesting. The clinical notes revealed that this case was used for calibrating a newly installed CT scanner. When you say calibration, that means, the procedure takes longer because they want to look at all the different things that they have to get right. Is the contrast right? Is this right? That right? And so on and so forth. The room temperature in the gantry room was 14 degrees centigrade. The procedure took 4 hours. You know how long a CT scan should normally take? I'm sure all of you know that now with the ultra-fast CTs, your CT is over in 15 minutes if it takes that long. In the days when this happened, a CT would take about half an hour, maybe a little more than that. But this procedure took 4 hours, okay? And the patient who had come in walking, although he was not in the pink of health, certainly not, he was moribund when the procedure was over. They actually had to lift him, because I investigated this, lift him from the table and put him into a wheelchair, and he was not at all well. They wheeled him from the wheelchair to the, his consultant's consulting room, whoever the doctor's consulting room in the OPD, and it took about 10 minutes for the doctor to actually see him, and he was dead when the doctor actually he was wheeled into the doctor's room. So, the cause of death was hypothermia in a severely cachexic patient with carcinoma of the pancreas and obstructive jaundice. Now, without an investigation of what happened, obviously this was not written in the clinical notes. What was written in the clinical notes that was very interesting to me, or was noteworthy, was that the patient was well, in the sense that he wasn't moribund when he came to the CT scan. This was not an emergency CT, so that the patient might not get off the table in a very good condition. This patient was for 4 hours in what was essentially a freezer, 14 degrees centigrade, and he had no fat at all. Okay, so he died like a lot of people who live on the streets in very severe winters, and they have very little, sort of warm clothing that is sort of provided to them, that they die of what we call exposure to extremely cold temperatures. Now, you would say 14 degrees centigrade is not so cold. Well, it's not so cold, yes. The people who live in Bombay, even 20 degrees or 22 or 23 is cold. But when you don't have any fat at all, and you are 4 hours shivering in this in a cold, very cold environment, this is what this patient actually succumbed to. All right. And we have now case number 5. Here was a male, 47. He had a direct laryngoscopy under short general anesthesia. Procedure took 15 minutes. The patient was fully awake and was being transferred to the ward. And he died suddenly in the lift. Actually, we had the nurse who was accompanying him, who also, sort of said that he suddenly, gave a little cough and then died. And the anesthetist, who had actually induced this patient for short anesthesia was also in the same lift, incidentally, going up to eat lunch. Okay, so this was just before lunch. And there was no morphological cause in this case to explain sudden death, because it was literally sudden death. Patient was fully awake, being transferred, to the ward on a trolley, and just died in the lift. Okay. Now, what are the causes of sudden death when you don't have any morphological findings? And there are all of these. Okay, acute massive myocardial infarction, and you can give your preferences in the chat box. Cardiac arrhythmia, sudden laryngospasm, drug reactions, especially anaphylaxis, poisoning. Cyanide can cause sudden death.
Most attendees feel it is sudden laryngospasm, ma'am.
Sudden laryngospasm. Okay. And of course, there is positional asphyxia. Okay. So do you think that reading the clinical notes would be able to tell you that this was sudden laryngospasm?
Some people have also used positional asphyxia, also possibility.
Positional asphyxia. Okay. The guy was lying down on his back with a small pillow under his neck. Okay. Now, do you feel that the clinical notes would be able to tell you something about this, say laryngospasm or positional asphyxia? Unlikely, right? Okay. But anyway, we had to do this autopsy. The anesthetist who induced this patient and the head of anesthesia were very concerned, and so also the surgeon. I mean, had they sort of done something to the airway? Was this, did the patient bleed or something, and they didn't know whether there was a bleed there? They were really worried that when, the autopsy was done, but they had no choice. The autopsy had to be done. That we might find that there was a whole lot of blood within in the airway, okay, and that a massive bleed or something. And of course, when the autopsy was done, there was nothing to account for this sudden death. Not even a tiny little blood clot that was present at the site, because no biopsy was taken. They just sort of had done this procedure, and that was that. Okay, so I was supervising the autopsy, and we thought that we would just have to say, the usual thing, that no morphological findings for the cause of death. But I said, just let me read the notes. And when I got the notes, this was what the notes revealed. The patient was an old case of cancer of the larynx. Okay, so, and he had had 2 previous major procedures under anesthesia, 2 years before the present procedure. And when I asked for the notes, what I got was like, 4 pages. Patient admitted on such and such day, seen by an anesthetist, fit for surgery, needs direct laryngoscopy or whatever else. And except for the orders for the preoperative, anesthesia, like, atropine and whatever else they had written down over there, there was nothing. And I said, what? This patient has had 2 previous major procedures in the same hospital for, can I have a look at the old papers? Now they ran around, sort of looking for the old notes and all that. And when they found it, they were very revealing. Those notes were, the size of a textbook. There were so many, heavy notes. And when I went through those notes, what I found? That this patient had died, I surmised that the patient died of uncontrolled ventricular arrhythmia, which was related to anesthesia. Why? Because on reading those thick notes, what did I find? At each previous surgery, the patient had suffered attacks of ventricular tachycardia, which were detected and reversed because the patient was being monitored under anesthesia. This time, they didn't think, what happens? No one thought to do a preoperative review of the old case sheet for what was considered to be a minor procedure. And the patient was reversed, everything, but the effects of anesthesia don't just disappear, just that way. And what the patient probably had, because, once he was out of the recovery room, and even in the recovery room in the days when, it was a long time ago, in those days, you young people would find it very amusing, but there were not these things that we take for granted now. No, you just put on, check your O2, check your, that means PO2 and everything, and COVID has just brought that into very sharp relief. Yes, the patients were monitored. They used to be, a nurse and a resident who would take their pulses and this and that and the other. But it's a minor procedure, minor theater. The recovery room in minor theater is, next door to this minor operating room. The patient was fine. He was awake, didn't complain of anything, and he was being shifted. When what took him away was very likely uncontrolled ventricular arrhythmia, because nobody knew that he had ever had attacks of ventricular arrhythmia that were related to anesthesia. Okay, so I'm at the end of this talk. It's a very brief talk. It is just that we need an explanation for many things. The explanation, the reasons for why we need to do an autopsy, which I explained, earlier on in this talk. I believe fervently in this one word, why. Okay, you have heard right throughout, and also in this autopsy series, what to do and how to do. And also you have heard why, because this today is all about why. Why do we need to read the clinical notes? Please, all of you young people listening, remember that what makes you a really good professional is this continual curiosity, the need to understand everything, to ask why. And like I said, the morphological explanation for death may be known. We knew pulmonary edema. In at least 3 of the cases, there was pulmonary edema. However, the reasons for the immediate cause may lie in events that are not reflected in the morphology, gross or microscopic. So therefore, there are many other things that you need to assess or to investigate before you give a cause of death, and particularly to explain terminal events. And all of these have to be investigated. We do histology, yes, chemical analysis, microbiologic analysis, molecular analysis, and please never forget the clinical notes. Because we are pathologists, we often overlook this simple matter of reading carefully the notes of the patient. People keep emphasizing that you must know the history, you must know the history. Well, the reason that you must know the history is not just an adage that, people keep telling you. There is a very practical reason for knowing this history, and a lot of the history is encapsulated in the clinical notes if the notes are good. Otherwise, you may have to interrogate patients' relatives, you may have to interrogate doctors, you may have to interrogate nurses as to explain why for whatever explanation you want, whether it's a terminal event, it is an event that has led to the terminal event, or whatever. And I think that the 5 cases that I discussed with you, each of them, or some of them, might have had similar terminal events, and that is left ventricular failure, pulmonary edema. But in each of them, there is a different reason as to why these patients died, and some of them you would not be able to figure out unless you had access either to the clinical notes or to a minute by minute or hour by hour end, terminal course in each of these patients. So I'll just end by saying that a good prosector, somebody who's doing an autopsy, should be a good pathologist. If you don't make good observations, you can't make good interpretations, and therefore you can't make a good diagnosis. Has to be a good anatomist, because an autopsy, to do a really good, elegant autopsy, it's not now just mucking about and hacking about in that. You must know your anatomy, because sometimes anatomy is the thing that will tell you whether something has gone wrong, or the patient was born with some kind of anomaly or a defect. And if anybody is doing, and a lot of people say that they don't get an opportunity to do adult autopsies, in many places they're doing neonatal autopsies or even fetal autopsies. Anomalies in the cardiovascular system in fetal autopsies can be the cause of fetal deaths. So I think, of course, looking at the placenta, which is also another very important thing. So you must be a good anatomist. You must be a good technician. Again, you should be very familiar with your forceps and scissors and how you go, and your scalpel and the big knives, as to how you should elegantly do a cut up. It's important. Otherwise, you cause all kinds of anomalous things, which if somebody else is examining that particular organ, you don't know whether this is been caused by the prosector or was actually there before life. You know that forensic pathologists need to do this all the time, right? If there is a stab wound, was it caused before death? Or was somebody trying to throw the scent off by stabbing the person after death? And saying whether it is before or after is very important. It has to be a good detective. That's what I just said. Your mind must be asking or getting clues out of all sorts of things: the morphology, the histopathology, the biochemistry, and of course the clinical notes. And to get the most out of clinical notes, we have to be good clinicians. Please, I don't want to hear the answer that I heard from one of my students, in the first case, who said, "Why are you asking me a third MBBS question?" Apart from being cheeky, I think that particular individual felt that there was no relevance of what he had learned in clinical medicine to what he was doing as a pathologist. Of course, I think he knows better now, but that was he never learned. He never forgot that particular lesson, I hope. So I would say you could invert this list. And, a good prosector needs to be a good clinician, because you get the clinical notes first. And then you begin to wonder, what do these clinical notes actually mean? And what should I be looking for, and how should I get at it? With the least possible disturbance to the dissection that I'm going to do. Obviously, you have to be a good anatomist, and altogether that makes you a good pathologist. I would just end by saying that you must read the clinical notes, both on and in between the lines, because quite often there is something that should have been written in the clinical notes that you suspect should have been written, but it isn't there. And then you can go on a search for whatever it is that you're doing. All right? So I think I come to the end of this talk. I will stop sharing my screen, and if I will ask Dr. Purva to give her little sort of remarks on my talk. and then we can take questions.
Thank you, madam. That was an excellent lecture, as usual. And this time, through different examples, the beautiful examples, you stressed the importance of clinical notes in the autopsy. It was really very good and must be very helpful for the students also. And for my notes, I'm just sharing my PPT. Everything you have told, but just to revise and repeat, because repetition will make them remember better. Can you see my screen?
No. Not yet.
Not yet, ma'am.
1 minute. Can you see now?
Yes, ma'am.
Is it visible?
Yes, yes. Could you make full screen, Pooja?
Yeah, it is full screen. Can you see?
Yes, ma'am.
Yes.
So as madam has already told you, being an autopsy room, it makes man really humble. So small distance between death and life is there. The moment before the patient is in the hospital at the hands of the clinician, and afterwards he comes into the autopsy room. And we as pathologists are playing very important role during life also, being a part of investigation team, doing all the investigations, interpreting them, helping them in diagnosis and in treatment also. And after death also, our role is equally important because we are the ones who are giving the cause of death in the cases where clinicians are facing the problem. The role of autopsy in medicine, it has got extremely important. You not earlier in
Dr. Purva. Hi, Dr. Purva. Dr. Purva. I think your voice, we're losing
Yes,
you,
sir.
Dr. Purva. Connectivity.
Your bandwidth is low.
Hello. Now it is. Hello.
Now it is fine.
Okay. So we as pathologists are producing the autopsy report, and that data is going to be important for the clinicians, for the patients, the relatives of the patient, and also for the community. And forming this important data of autopsy report, we need certain information, and that is what we are talking today about, that are the clinical notes, which is the case papers and the digital records and whatever information from the clinicians or the relatives of the patients that are given us, that forms the important source on which we are building our diagnosis, that is the cause of death. As madam has already told, the importance of clinical data is that it is all the information that we gather before starting the autopsy. It is the journey of the patient in the hospital, right from the entry in the hospital till the entry in the death room. So all that information we have to read, we have to understand, we have to formulate how the sequence has taken place in his life, and then we have to plan our autopsy, how we are going to proceed, which system we are going to focus on, depending on the signs and symptoms and the investigation, the reports they are pointing towards. This also help us in doing certain modifications in the autopsy process, like which organs to be taken out, the order of the incision, the order of taking out the organs one by one or in block dissection. It also gives us idea about the infectivity if the patient is high risk patient, and we have to take precautions. Actually, each case we have to consider as high risk autopsy and should take universal precautions while doing the procedure. It also decides, as madam has already told us, we have to what post-mortem investigations we are going to do and what samples we have to collect. That all information we take, and we think when we go through those records, very thoroughly and understand it. And all that also helps us in forming our clinico-pathological correlation with examples. Madam has already stressed that, and ultimately deciding the cause of death. We pathologists are also important source for giving this information regarding the cause of death or the mortality statistics. So we should be very careful about writing how we write the death certificate. So I will like all of you to go to this WHO site in which there is this description about different diseases that we need to know. There are certain codes given for each disease. We need not put those codes because we are not coders, but we are certifiers. So we should certainly know about this coding system and of course how to fill the death certificate. In that there are two parts. The part one being of various subparts, of which the first important A column, it consists of the immediate cause of death. As Madam explained in her case, pulmonary edema, that was a cause of death. But we have to also think about the antecedent causes and the underlying, the main cause to which we have to arrive. How we can arrive to that? It is just by going through the notes and correlating them with what histology we are seeing, what gross findings we are seeing, and histologically then we are confirming our findings. So it should never be just the morphological diagnosis or the anatomical positional diagnosis, but it should always be correlated with the clinical notes. Then only we can write this death certificate. I will show you the example, as in this case of the death of a patient because of excessive bleeding, the hemorrhagic shock, which was caused by bleeding in the esophageal varices, which was noted by reducing hemoglobin in the patient and patient going into the hemorrhagic shock in the clinical thing. And also morphologically on gross examination, we were seeing the esophageal varices. But that is the immediate cause of death. But the main cause, the underlying cause, was that the patient was suffering from hepatitis B, and this we came to know because of going in through the notes, and of course the microscopy which was showing the chronic hepatitis changes. So we have to sit and write out this sequence of events, the CPC, and we have to write it and explain it while we are writing this death certificates. Nowadays, the number of autopsies are going low, and students are not aware about how to write the death certificate. So just have a look at that also. And this is same thing. We have to correlate everything, clinical, morphology, histology, and give the CPC. As the autopsy number is nowadays decreasing, but the new the concepts of virtual autopsies, minimal invasive autopsy, or even the rapid research autopsy is coming. But in all these cases also, the importance of clinical notes is of course there, and we have to read, and we have to read the notes, we have to understand the notes before entering into the dead house. After coming back, after reporting also, we have to correlate the negative autopsies when we are not getting anything in the gross or microscopy. Those cases can be solved by this clinical notes. Thank you.
Thank you so much, Purva. That was so relevant, and you know, it added a lot of fleshed out a lot of detail to whatever I had just talked as clinical. And for those of you who don't know that this is the picture that is there, Purva, explain the picture that you have put here. This is iconic.
Yes, this is from the Grant Medical College. In our museum, it is there. And it aptly tells you that how the meaning of autopsy, how the date teaches the livings.
Yes, that's good.
Thank you, ma'am. Ma'am, we request you to please stop sharing the presentation, ma'am.
Yeah.
Ma'am, in the chat box, there are no queries, but there is one pointer from Dr. Anshu. He mentions, although the onus is always on us, like the principle of reading notes carefully holds true for all branches of pathology. In fact, But it is frustrating when we get blank requisitions and we have to summon the patient notes, which are often badly written or they are incomplete.
Yes, I think that this is the, the cross that all pathologists have to bear. But I think, then I consider it as an opportunity. Rather than, something that we should grumble about and generally, say that clinicians are so bad, they don't share what they know, etc. I have taken it, in my life as an opportunity, in the sense that if I don't have, information that is given to me, perhaps if I go and dig for that information myself, I will find more than what the clinician might have, shared with me. And this happens, literally happens every day. Because when you talk to the patient, I mean, I'm talking about surgical pathology now, can't talk to a patient who is lying on your, autopsy table. But when you talk to the patients, you talk to the relatives, you often get more information than when you talk to the doctor, because the doctor is looking at the patient quite often through tunnel vision, and has not looked left, right, or anywhere else. And if it is above the clavicle doctor, he doesn't know what's happening below the clavicle. And if he's below the clavicle doctor, he doesn't know what's happening above the clavicle. So sometimes, if you interrogate the patient and the patient's relatives, you would get a lot of information which otherwise, would be. So take it, this lack of requisition forms being poorly filled, etc. Take it as an opportunity and a challenge, rather than shrugging your shoulders and saying, no information available. The clinicians do it all the time. The patient had an operation, but no information available, notes lost. But it's amazing how many times if you dig, you will find those notes. You might find it in, if you ask, where was this operation done? Oh, in so-and-so hospital. Do you know more or less the time when it was done? And they'll give you the date. And lo and behold, you'll be able to get some gems of information out of you doing the hard work, And I still think that there is no substitute for good information. And if you have to do the hard work, then you do it. And you train your young residents, etc., to do it. And they learn, how to ask follow-up questions of patients. Yeah, so all of this is important. I see Dr. Lanjewar there. Have you unmuted Dr. Lanjewar? Dr. Lanjewar, can you ask to be unmuted, please?
Yeah, I've sent a request. Sir, I've requested you to be unmuted.
Please unmute. Danesh, can you hear me? Just unmute yourself.
Me.
There. Good.
Okay. Anita, it was a wonderful presentation.
Thank you.
All 6 cases were good. The most important thing is that if we always go for a postmortem, and before going for postmortem, we read a case paper. And in your all cases, all the discovery of clinical notes was made after postmortem when cause of death was not found. That is more important. When I do not find anything, let me go again in detail what is there in the case paper. This is the beautiful message which you have given today.
Thank you.
Thank you, sir.
But as Anshu says, it doesn't apply just to the autopsies, it applies to life as of a pathologist in general. Well, every clinician should have as much information as required. But, people say, no, it's too much trouble to do it. Nothing is too much trouble if the patient is the focus of your, whether the patient is alive or the patient has now, is no longer with us. There is a lesson to be learned from every case that you see, and the more
Absolutely,
information you
absolutely.
have, the better.
Ma'am, I have a question from my end, and regarding the cases which I saw, most were related, if I may deduce, that there was a patient safety issue which was to be learnt after the conclusion of the autopsy. How much was the autopsy report helpful, in implement? Like you said, for the pentazocine case, later on it was decided that no longer there will be an unsupervised administration of pentazocine. Likewise, were the other reports helpful in enforcing something?
Yes, certainly. If you're working in an institution where the management is really or the administration is wanting to learn lessons from the autopsy, where you have death conferences, you have mortality meetings, you have autopsy meetings, for that matter, where you have team discussions of any sort, whether it's on the surgical pathology side, lessons are learned. Now, I'll tell you this thing where the patient died of hypothermia. Okay, this was a CT scan when it was first installed, and there were 1 or 2 patients who had gone on that CT scan before this very cachectic patient went on. Now, they were provided with very thin blankets, and they were healthy, otherwise healthy individuals, but just needed a CT for some minor purpose or whatever. They also complained that they were shivering, but you know how it is, nobody pays attention. Thanda rakhna chahiye. After this, what happened was, is this supposed to be so cold? It is because the computers need to be kept in a chilled environment. Now CTs are completely different from what they used to be once upon a time. The computers have become smaller and smaller and smaller. And you don't need to keep your computer in some chilled environment. But at one time, they were huge computers. They were banks of computers. So they had to be chilled. So what was done, and so the whole CT suite was chilled. So the doctors were there with their coats and their everything, the cardigans and not blankets, but shawls and whatnot. The patient had some 2 or 3 thin blankets. So after that, they disconnected the the cooling system that was for the computers to the from the rest of the CT suite, and the temperature from being 14 or whatever came up to 23, 24. So I think, yes, if there is a commitment to doing this, and the anesthetist learned that there's no such thing as a minor procedure. Everything has to be taken as if precautions, as if once you're putting a patient under, you must know all the antecedent history. How many patients have suffered anaphylaxis under local anesthesia because they never ask, have you ever had local anesthesia before? Dentists, in dentist rooms, patients collapse. Have you had local anesthesia before? They don't ask the question. And this is where, this wonderful book, which is called The Checklist. Checklists were devised because there were disasters that happened, But in this case, I suppose the anesthetist went through the checklist, okay, but didn't ask for the old notes. Have you got dentures? No. Checked. Have you, and so on. They have that little checklist. But I think that they learned the lesson. Certainly the head of anesthesia was very, very chagrined that something like this would happen in an institute where you are otherwise so careful about seeing that nothing goes wrong. A little slip and you can have a problem like this. Yes, so yes, the message has to also go across. No? So if there is an organizational way of sending the message, good. But even talking to somebody and not saying, haha, this is what you did. It's a way of communication. An autopsy report, apart from everything else, is a communication between, the person who's done the autopsy, pathologist, the patient's relatives, as well as the, I think somebody said it. I don't know whether it was Vishan or Danesh, that it also is of comfort sometimes to the patient to know that, this was just an inevitable thing, that there was no, something that had not gone wrong, particularly after surgery, There was no leak, there was no this, that, and the other. It was inevitable that. So these are things that.
Thank you, ma'am. I think on the whole, I can sum it up again by using Dr. Anshu's words. You brought the autopsy to life. Thank you so much for your talk.
Yeah, the previous speakers also did that, Ganesh and Vishan, I don't do that many autopsies, not before. Once I became an oncopathologist, didn't do that many. I supervised quite a lot, but it was a joy, to do a good autopsy. And I'm sure Danesh would do that. If you're familiar with your scissors and your forceps and you find planes, it's like doing surgery. It's so beautiful, to open the planes and do it. That's why I said, if you're a good technician, that, the feel that you get that comes from your instruments through your arm to your brain is really, really so good. And Danesh, I don't know about Vishan, but of course he's had really good prosectors there. But Danesh, I remember Dr. Ranamvare, Professor Ranam, he was my teacher, of course. They did such elegant autopsies. Really, you see the elegance of this whole thing. And it does not have to be a chore, that somebody else can do. I don't want to do it. It's such a bore. It's such a chore. No, it can be so elegant. It's not all that, dipping your hand into blood and gore and all. You can make it so, but it doesn't have to be. It really doesn't have to be, I remember, and I know it's ridiculous to talk, the old ladies talking about old things, but, to collect, to get the alcohol level in a patient. And we used to do forensic autopsies as well as routine autopsies, I'm sure. And there can be a problem. Was this patient really under the influence when whatever, the accident happened or this or that? We used to collect vitreous and send it because in the vitreous, you don't have the enzymes, because it is a enclosed area, but it reflects reasonably well the level of alcohol in the blood. And after death, all the organisms, etc., are everywhere, and they break down the alcohol. So if you take blood and send it for any organ, you will not get the actual alcohol content level. But the vitreous will have that alcohol level to a great, it won't be accurate if you had taken it ante-mortem, but you will get it. And it is, I think, there are so many little elegant tips that I used to enjoy the thrill of finding out something. And that I think all pathologists should have, no? To be able to find out something. God, otherwise, why are we pathologists? Yes, curiosity. Why? Anyway, I think I've talked too much on a simple subject like reading the clinical notes. Thank you. Thank you, all of you, for listening.
There is a comment for the team from JJ also. Dr. Sujata says, I remember the work done by Dr. Professor.
Yes, Dr. Vagulkar, yes. My God, everybody should know about that case that, where he solved the glycerine, which was the glycerine that should have been administered to patients with intracranial tension, high intracranial tension, and it was glycol that was, industrial glycerine that was administered. And that was which commission was that sat over there? Justice
Lentin Commission. Lentin Commission.
Justice Lentin Commission. Yes.
It is between January 14 to 21.
Yeah.
18 death occurred.
Yeah, in these patients, no, with
And
ophthalmology.
all patients, they were admitted either for increased intracranial tension or increased intraocular tension. They all were given this glycerine, which
Yes.
was mixed with diethylene glycol, and all showed renal cortical necrosis. That was the one thing which Professor Vagulikar picked up. Why this is happening? So rare disease, found so frequently, in a span of 10 days, 18 cases. That was the point where investigation started. And then he proved everything by chemical analysis and injecting it into the rabbit. And he
Yes,
proved
and glycol crystals, I think, also, no? There were crystals that had, but, the question, why?
it was
Why?
liquid, right? It becomes less expensive. Only thing is that industrialists wanted to earn more money out of this. And then there are examples in the literature about this diethylene glycol, that this is not the only case. There are several 10, 20 episodes like that happen.
Mm. Now, why? I'm telling you, why? Just ask why. Be curious. And the curiosity that I tell students, you're young, and the curiosity that you demonstrate when you see two people going out together on more than 2 or 3 occasions, that curiosity as to why are they seen together, I think if you apply to why is this happening in in my everyday professional life, I think you would be, because everybody is curious. Only thing is you have to direct your curiosity. Okay.
Thank you, ma'am. Thank you, ma'am. There are a lot of compliments on the chat box, and particularly they thank the efforts of the organizers in the enthusiasm in arranging these talks. So I think that is what is keeping going these sessions, and we request more and more attendees to join also. And I request Dr. Deepika to take over.
Yes, sir.
Thank you, Purva. Thank you very much.
Thank you, madam.
Yeah, Deepika.
Ma'am, 1 second, ma'am. Ma'am, thank you very much for your excellent talk. I'll just share the next talk. Yeah. Oops. Okay. This is our upcoming talk tomorrow, on Thursday, on infective diseases of the brain by Dr. Anita Mahadevan. We look forward to seeing you all and many more probably on Thursday. Thank you.
Thank you. Thank you, madam. Thank you, sir.
Thank you, Anita. Good night.
Good night. Bye, Danesh.
Bye,
Good
bye,
night.
bye.
Thank you, both of you, Ram and Deepika.
Ram, you have to stop the video. Thank you.
Okay.
Recording. Yeah, thank you.